Suboxone in the emergency department. Why initiation in the ED is best practice. Today we're going to talk about the current state of the opioid crisis. What is opioid use disorder? What does the science say about it? Why the emergency? How do we implement this? And what are we going to do next? This image is depicting the current trends of illicit drug toxicity deaths in BC. On the left and the blue bars are deaths by number, and on the right is the death rate per 100,000 depicted by the dark blue line. Despite many provincial initiatives, the opioid crisis is not improving, only getting worse. We need to figure out how we can do our part. Please note the drugs used for all these deaths include street drugs, 90% including fentanyl, medications that are obtained or purchased on the street, and prescription drugs. In January and February 2021, in BC, there were 6 deaths per day. That's a 107% increase from 2020. In interior health alone, there was 1 death per day. In contrast, during that time for COVID-19, there was approximately 3 deaths a day in BC. Untreated opioid use disorder is the main driver of the opioid crisis. What is opioid use disorder? It is characterized by 4 C's of addiction: loss of control in the amount or frequency that you use, cravings, compulsions, and use despite consequences. These are based on criteria in the DSM-5. Opioid use disorder is a treatable medical condition, and it needs to have the same response as somebody coming into the ED in a rapid AFib or a new DKA or a stroke. We identify, we look at inclusions, exclusions to treatment, we intervene as needed, and we refer as required. Initially, the pleasure and escape derived from opioids is what promotes its use. But not all people that try harmful substances will develop addiction. Many factors, such as adverse childhood experiences, also known as ACEs, other biological, psychological, socioeconomic, or environmental factors influence whether the person that experiments with drugs will continue taking them long enough to become dependent or addicted. Things like the loss of a child, history of child abuse or neglect. Maybe the person was in a big accident as a youth and is just looking for an escape from those memories. Perhaps they lost their job, witnessed violence against someone they loved. Whatever the reason, this increased vulnerability or reason to look for that escape keeps them coming back, looking for some kind of pleasure or feeling of well-being. We need to take that trauma-informed, universal approach and assume everybody has gone through some kind of trauma. They don't need to disclose it, but we need to approach all our patients in a way that makes them feel safe. Eventually, this repeated exposure of drugs in that brain when they're in that cycle changes things all the way down to the receptor level, then causes withdrawal and cravings and leads them to using again to get rid of that terrible feeling they're experiencing. In the end, some say it is more about reducing these terrible feelings of withdrawal than seeking the pleasure that initially kept them using. This image is an example of what is happening at the level of the dopamine receptors in our brain, with either normal activation or when a person takes opioids. We're going to get into them more in a second. In the normal reward pathway, endorphins travel through the bloodstream to the brain and attach to mu opioid receptors on the surface of opiate-sensitive neurons, which then release dopamine. Dopamine is associated with feelings of pleasure and happiness, and activation at normal levels reward normal behaviors, such as eating, sex, hugging your children, all things that are important to our overall survival. We need to do them. When this reward pathway is so-called hijacked by opioids, it floods the system with 2 to 10 times the normal amount of dopamine. This overstimulation produces euphoric effects, these extremely pleasurable and intense feelings of well-being and happiness. These effects strongly reinforce the behavior of substance use, creating dependence, and effects can be almost immediate depending on the route, again reinforcing their use. So how does this repeated stimulation change things long term? Shown on the left, these PET scan images show the amount of dopamine receptors in a healthy person. In the middle, a reduction in the amount of receptors available. So just like we turn down the volume on a radio that's too loud, the brain adjusts to the overwhelming surges in dopamine by reducing the number of receptors that can receive signals. If a person were to stay in this spot, there's an increased threshold for experiencing reward and pleasure. This creates diminished interest in non-drug rewards, and the person living with substance abuse no longer enjoys the daily life experiences they used to. This starts those cravings, that intense desire to use, looking to get those feelings of pleasure again. On the right is the recovery of some of those receptors. This shows that the brain is remarkable and able to recover in part from those changes. They just need help to get there and can't change on their own. Taken from the Canadian Medical Association Journal in an article on behalf of the Canadian Research Initiative in Substance Misuse. As you can see, after the diagnosis of opioid use disorder, using the DSM-5, if opioid agonist treatment is indicated, the first-line preferred treatment is buprenorphine naloxone, commonly known as Suboxone. Also note on the right-hand side, things to avoid is withdrawal management alone. We've now learned that over 90% in this category would relapse, and most within 7 days. Although buprenorphine naloxone is the preferred option due to its safety features, all these options of opioid agonist treatments are great, and really any OAT treatment is much safer than untreated opioid use disorder. You may be asked, how is buprenorphine different than other full agonists that are currently being used? Buprenorphine, as you can see from the yellow dots, is a partial agonist. It attaches strongly to the opioid receptor, but does not activate its full effect. As you can see on this chart, they refer to this as a ceiling effect. This means it doesn't reach that respiratory depression threshold and has little to no euphoric or highly pleasurable effects. However, it gives enough activation to control those cravings and withdrawal. The full agonist is like the red dots. When it attaches to the receptor, it fully attaches, giving a full effect. Patients will still experience some euphoria, and there's no ceiling effect, so it can cross into that threshold for respiratory depression. Suboxone is really two drugs in one that can't be separated, buprenorphine and naloxone, together called Suboxone. First, we'll look at the role of buprenorphine. In the top left, you have an empty mu receptor. This mu receptor is showing signs of withdrawal or pain. Then top right, along comes a full agonist opioid. It connects perfectly to the receptor, gets rid of the withdrawal and pain, and creates this euphoric, extremely pleasurable effect. Bottom left, the buprenorphine has a very high affinity for the mu receptor. It is very sticky and will come and displace the opioid from the receptor. It fits, but it's a partial opioid agonist, a so-called imperfect fit on the mu receptor. This means it will stay stuck on the receptor, but will not produce the full effect of the receptor. Therefore, less euphoria, less sedation, and less respiratory depression. The bottom right, the buprenorphine continues to block the opioid from the receptor as it dissipates. It starts to work in 30 to 60 minutes, but with a half-life of 24 to 60 hours, it will continue to relieve opioid withdrawal and craving for 24 hours or longer. Lastly, the naloxone component is not bioavailable sublingually, so when Suboxone is taken as directed, the naloxone does nothing. However, it is activated when it's injected. If someone injects it, the naloxone will displace any opioids and the patient will feel worse. Therefore, this creates a very low risk of diversion or misuse. A common concern with giving Suboxone is precipitated withdrawal. As you can see in this first image, the person has opioids on their receptor. They're experiencing that full effect of the opioid receptor. If opioids are actively on that receptor and then you give the person buprenorphine, as we learned earlier, the buprenorphine will knock off any opioids on the receptor and will only give a partial activation. This change in feeling and will bring those terrible feelings of withdrawal quickly, usually 30 minutes after the Suboxone. This feeling can be so terrible it might deter the patient from trying Suboxone again. One way of checking whether or not those opioid receptors are empty and ready to take in that buprenorphine is through the COW score. This must be done before initiating Suboxone, and it must be above 12 to start. We'll get into more about what happens if somebody does end up into precipitated withdrawal and how to treat it later. There continues to be many myths about the use of buprenorphine naloxone. Some people say it's very complex to use it, where it's actually much simpler than titrating insulin for a DKA. Others may say it's just a replacement addiction, but as we recall from earlier, addiction requires person to have compulsions to use that loss control and use despite consequences. Taking a prescribed medication to manage a chronic illness simply just does not meet this definition. Some may say that detox is effective. There is absolutely no data showing this, and actually it shows that it may increase the likelihood of overdose by eliminating tolerance. And also that Suboxone is the same as methadone. Methadone is a full agonist opioid and doesn't have a ceiling effect. Therefore, there's a higher risk of overdose, and methadone has many more drug interactions and prolongs the QT. Others may say that initiating Suboxone is time-consuming and cumbersome, but with our new protocols, it's actually quite straightforward, and studies have shown that treating these patients can be very rewarding. I believe I may have said this, oh, patients are going to flock to the ED now. They're already coming to the ED. So studies have shown that sites with ED initiating Suboxone have not seen an increase. And actually, once they're treated, they're going to come less. Others may say it's unsafe. It's actually extremely difficult to overdose on Suboxone due to the ceiling effect, and the naloxone component reduces the risk of misuse. And that initiating Suboxone will increase their length of stay. Actually, studies have shown that over time, as staff get comfortable with initiating Suboxone, that it will reduce their length of stay and also reduce their potential for violence towards staff. You may ask yourself, why the emergency department? Well, it's where the patients come, whether they're coming due to an overdose, they were seeking treatment, or many are here for something else. 15% of patients with an opioid-related death visited an emergency department within 30 days before their death. They're coming to us for help, and we have the help. We're just not using it. I've heard many people say, this is the emergency department, and yet my beds are full of patients with mental health and substance use. We need to change our thinking. 10% of ED visits just on CDIS complaint alone are mental health and addiction related. We spend tons of time training on CTAS-1 type complaints with resuscitation, with ACLS, PALS. That's only 0.01% of what we see. We need to start taking more time to ensure we are giving best practice to the mental health and substance use population. Studies are even saying that although 10% is CDIS complaint alone, likely many, many more that are coming in with your abdominal pains or cellulitis or gastros are actually related to substance use and or mental health. Studies have shown that when initiated in the emergency department, buprenorphine naloxone doubles the rate of retention in addiction care. 80% of those continue in community care if we initiate it in the ED. That is what we want. We want these patients to be supported and cared for after their visit in the emergency department. And in the end, there will be fewer ED visits related to their opioid use disorder. You may ask yourself, can I even make a difference? Well, 25 years ago, France had a look at their overdose crisis and decided they needed to do something about it. They removed all barriers to prescribe buprenorphine and started initiating it. As you can see by this graph, significant change related to the initiation of buprenorphine and the decrease in their overdoses. This remains their practice decades later. So can you make a difference? Yes, one person at a time, you can make a difference. So how are we going to do this in the emergency department? Like everyone else, this image is taken from the Emergency Services Network patient journey map for the journey of every patient that comes through the emergency department. So we're going to identify, we're going to initiate best practice, and we're going to refer, just like we do with everyone else. This process follows the clinical decision support tool that was created provincially through the LOUD and the ED program. As we go through the PPO, we'll get into some of these details. To accurately identify opioid use disorder, physicians will use the DSM-5. There needs to be at least 2 of these symptoms present to indicate opioid use disorder. However, the bottom two, tolerance and withdrawal, can't be the only two. They can be used in conjunction with another symptom, but they just can't be the only two. You might think that the DSM criteria has a lot of components to it. However, to bring it back, if you think about those 4 C's that we talked about earlier, the loss of control, the compulsions, the cravings, and the use despite consequences, they are embedded within this DSM-5 criteria. So if we continue to think of those as a quick guide, and if a patient has one of those components, likely they would meet the criteria for opioid use disorder. So we've decided our patient has opioid use disorder. The next step in initiation of Suboxone in the ED or sending a patient home with a take-home pack is to check our inclusion and exclusion criteria, the same as we would before we'd give TPA for a stroke. And this criteria is actually, there's less components. If there's any questions, like if the patient is pregnant, that is a relative exclusion. Definitely call the Race Perinatal Addictions line that is located on the PPO. And there's also a 24/7 addiction medicine clinician support line that is there for any questions you may have. Next, in determining eligibility for Suboxone induction, whether that's in the ED or home induction, is first to check sufficient time since their last opioid use and whether their COWS is greater than 12. Next, in determining eligibility for Suboxone induction is 1, whether there's been sufficient time since the last opioid use, and that depends on what type of opioid they used, and 2, is their COWS greater than 12? If both those criteria are met, we can do an ED induction. If they're not met, that's when we need to think about a home induction, and we'll talk about that in a minute. So what is this COWS score? It stands for the Clinical Opioid Withdrawal Scale and is used to determine how severe the withdrawal is. The patient needs to be in at least a moderate withdrawal in order to initiate Suboxone, which is the over 12 score on the COWS score. Once we've determined that they're over 12 and we can initiate it, we will check the COWS score at least once or twice after, within the first hour to 2 after the Suboxone, to check if there's any evidence of precipitated withdrawal. And after that, then there's no further COWS scores required. So if we've met both our time and our COWS score above 12, we can do an ED induction. We're going to start by giving 1 tablet sublingually. Patient is not to chew the tab, but to allow it to dissolve under their tongue. We'll reassess the COWS after 30 minutes, looking for evidence of precipitated withdrawal. And if after an hour after that first dose, there's still no evidence of precipitated withdrawal, we can continue to give 2 milligram tabs to a maximum of 12 milligrams. And please note that although it's a maximum of 12 milligrams, this should also be our target dose. Patients have better outcomes when they take the max dose on day 1. So not only is it our max, but should be our target. So what happens if there's evidence of precipitated withdrawal? According to the BCC-SU guidelines, the preferred treatment for precipitated withdrawal is actually to continue the induction. However, consult the addictions medicine support line, and whichever option you choose, make sure you explain to the patient that what they are experiencing is temporary and that if they continue with the Suboxone, they will feel better. You can also possibly give non-opioid treatments such as clonidine, some antiemetics, NSAIDs, whatnot at this time. If the time since last used or the COWS is not sufficient to start Suboxone in the emergency department, consider a home induction. One of the great additions to this program are these to-go Suboxone kits with 3 days worth of Suboxone that they can take in the comfort of their home. The kits themselves contain enough medication to last 3 days. This should hopefully be enough until they get to their appointment within 72 hours. Make sure they have their take-home instructions, emphasizing to wait as long as they can before starting. There is a link to an educational video on the top page, a QR code, as well as a URL on the last code if they just want to type that into their computer search engine. The last part of the ED journey is referral. To ensure that this patient is followed up in the community and that the medications you have dispensed are on PharmaNet so the community can view that, need to make sure that this referral dispensing form gets filled out properly and sent to both pharmacy and the urgent note at interiorhealth.ca. After the patient leaves the emergency department, they will be followed up within 72 hours. When they have that appointment, the clinician will make sure that they have enough medication to continue. They will enroll them for Plan G if they need financial support, and they will continue to support them until they are connected with the OAT clinic. Sometimes the patient might not be ready. Perhaps ask why. There may be myths or misinformation that you can clarify. However, if it's still no, there is some information pamphlets about both Suboxone and general OAT treatment that you can give them and that they can read on their own. And remember, always let them know where they can return for help and provide them with harm reduction supplies such as a naloxone kit. The history of medicine is, in part, the history of physicians stretching the scope of their practice to answer the pressing needs of their time. Our job is to keep patients safe and help them live their lives to the fullest. Remember, it's easy. Identify, initiate, and refer, and together we can change the trajectory of the opioid crisis.